Well, good afternoon, folks. Welcome back. No chime? Yeah, somebody's got to do the ding. But so welcome back. Thank you so much for getting settled in your seats. We got an exciting program this afternoon that I think will be just as stimulating as this morning. I want to thank our morning panelists and speakers who did a really outstanding job of laying out some of the key issues that we'll be developing further as we go into this program. We were asked to talk about those commission papers that I mentioned and the timing of when those papers will be released. Several authors of those commission papers are in the room today. We are gathering the conversation and the dialogue from the day, and hopefully that will help to provide some additional feedback for the papers that folks are writing. And then we anticipate releasing these papers over the course of the summer and fall, maybe every 4 to 6 weeks or so, to create a steady drumbeat of issues and new ideas, new visions that will be surfacing in these papers. So we're going to begin our afternoon with exactly that issue, the issue of vision. And how do we begin to imagine healthcare systems that are built around equity and are focused on helping to ensure that populations have the best healthcare that they need and conditions for health. So I'm really delighted to invite to the stage, I think, one of the most visionary leaders in our field, Dr. Tony Aitan. He's the Senior Vice President for Healthy Communities at the California Endowment. Those of you who know Tony know that he has been a leading thinker behind a range of societal and political determinants of health, also assisting with the Bay Area Regional Health Inequities Initiative, which has inspired so many of us. So folks, please join me in welcoming Dr. Tony Aitan.
Well, good afternoon. I get the pleasure of both following David Williams, which is, I'm already freaked out about that, and, being on the West Coast time delay, so you all look kind of like weird blobs to me right now. And then remembering that everybody on the East Coast wears suit jackets to meetings. And I'm like, where am I, at a funeral? Or what is happening here? But anyhow, it's a real pleasure to be here. Thank you, Brian and Kima Joy, who've just really been a joy to work with. Some of my favorite people are in the room here today. I want to particularly call out Risa, who's just been an inspiration to me, and your leadership at RWJF is just, it's been so helpful to me throughout my entire career. I mean, there's always some RWJF sort of support that I got at some point in my career. And whenever I looked over there, you were at the helm of it. So I know that you were doing something over there that was helping me. Thank you. And good to see Rich here too as well, and Joseph and some of our other colleagues. And then, of course, in the back, my good friends, formerly from GIH, Osula and Faith, who, whenever they're in a room, the room is just a sunnier, better place. So I switched a few of my slides out because after I saw David's presentation, I was like, oh, damn. Now I got to pull all these slides out. So my writing partner in this is Damon Francis, who's actually been a colleague of mine for many years, and it's always a joy to see Damon shine, and thank you for the panel that you just did. So I'm calling this Health Systems in a Healthy Society, and it's a vision for a new social contract for racial equity. And at the California Endowment, we're very lucky. We're in a state where there's actually traction for a lot of these ideas, and we've been able to prove that we can actually make change in ways that have fundamental impacts on health equity for people, particularly people who have been stigmatized and marginalized. So I want to tell you a little bit about the learning from that experience, and it'll describe and track a little bit of what the paper that Damon and I are writing is about. So we want to think about what does a health system look like that creates and enhances health equity and racial equity. And we thought that the 4 fundamental questions we had to ask ourselves were, 1, what creates health? Where's the genesis of health? And then how do we collectively preserve and enhance that? And then how does a health system leverage and strengthen the assets of differing populations? And some of the examples that we're going to dive into in the paper are really examples of health systems that they're more than patient-centered, they're even more than people-centered, they're really culturally centered, systems of health, and that's tricky in a very diverse world. And then finally, how should these systems be governed? Okay, so within each of these questions, we have an embedded principle. When we talk about the genesis of health, we recognize that health is not healthcare. And, one of the frustrations many of us have in this field is that healthcare sucks up so much of the oxygen in the room that sometimes we forget that, it's only 15%, maybe 10% of health status, and so much else happens outside the doctor's office. And that health is fundamentally about opportunity. It's about the balance between risks and opportunities. It's the ability of people to navigate an environment and essentially leverage their natural talents and genius. And the environments that we create they're largely policy-mediated environments, which I'm going to talk a little bit more about. How do we preserve and enhance it? This requires a strong social contract. And, sometimes people, when they hear social contract, they say, oh, whoa, that's socialism. Stop talking about that. And that couldn't be further from the truth. The Declaration of Independence is a social contract. It's actually grounded in concepts of a social contract. The New Deal was a social contract. We engage in this all the time, so I'm going to delve into that a little bit. The third question is, how does the health system leverage these assets? And this is about people-centered, culturally centered institutions that are essentially guided and driven by the people that they're intended to serve and incentivized by the well-being of those people. And then finally, how should the system be governed? Now, this is an area in California where there's a lot of exploration going on and elsewhere in the country, and I think it's one of the more exciting areas. It's fundamentally at the heart of the problem of our health system, is that it's not governed by the people who ostensibly it is meant to benefit. Okay, so the genesis of health, and this audience doesn't need to hear this that much, but in the paper we're going to have to talk about it because most people don't really think about the genesis of health. And when you think about the genesis of health, you recognize, and Robert Wood Johnson has done so much work in this space, the conditions in which we are born, live, work, and play. Well, what are those conditions? What shapes those conditions? What do we understand about those conditions? Well, we know that, in the 80s, a group of countries from around the world came together around the Ottawa Charter and started kind of putting together the sort of elements of the social determinants of health. They were insistent on centering policy, healthy policy, in public health and internationally. There was also roughly simultaneously a healthy communities, healthy cities movement that was growing up in the mid-'80s. There's a concept called salutogenesis, which is really the opposite of pathogenesis. And it's this idea, it came from this guy, Aaron Antonovsky, who was an Israeli, Canadian-American, who was perplexed by the fact that after the Holocaust, some people seemed to sort of just rebound and live these healthy lives, and other people never quite recovered. And so he developed this concept of salutogenesis and looked at some of the differing factors that may have explained some of these different reactions to the stress and trauma of the Holocaust. And then finally, we're now into Healthy People 2030, which has a kind of a nice, well-encapsulated concept of the social determinants. So salutogenesis, as I mentioned, Aaron Antonovsky, I'm not going to spend a lot of time. One of the interesting things about salutogenesis is that it tracks fairly well the work that we've been doing at the California Endowment, where we recognize that the key ingredients for improving community health are what we call ABC. And we refer to them as agency, which is really power and control at the family and community level. B is belonging, which I like to think of as the opposite of racism. It's the sense of being seen and considered in your full humanity and having your story known to others and knowing other people's stories. And then C is what I call changing the odds, because we spend a lot of time trying to help people beat the odds, but we don't recognize that the odds are fundamentally policy-mediated odds. and we have full control over those odds. And oftentimes we act as if those odds are immutable, and they absolutely are not. And that's been our experience in California. So salutogenesis tracks some of those ideas. There's also the Ottawa Charter, which again was about policy, the centrality of policy in creating the conditions for people to be healthy, and then healthy cities and healthy communities, which goes back 30, 40 years, talking about the environmental conditions that we know are highly correlated with the health and well-being of communities. And of course, in the social determinants of health, this comes from Healthy People 2030. You'll note that most of these determinants are really subject to policy. And that's sort of the big takeaway. So we know all of these things. This is not news to us. The question becomes, what does this child need? What does this child need in order to leverage her opportunities in life and to take advantage of the talents and gifts that she's endowed with, and from the moment she is conceived? And we recognize that, there are a whole host of things that a child needs. Science is rife with examples and proof of that concept, yet when it comes to your health in this country, your zip code is more important than your genetic code. And the question is why? And of course, here's where, I was like, well, David Williams is speaking, so everything I know about this, I know from David Williams. But the reality is we haven't created environments intentionally. Intentionality is a big theme in this meeting thus far today, and I think it's a great theme. We have to acknowledge the intentionality of the structural, systemic racism and the legacy of slavery that we're still dealing with today in our policies and institutional practices. And so when it came to creating the environments that we need for people to be healthy, we did the exact opposite when it came to African Americans and Native Americans and other populations. We physically separated them from opportunity with intention and baked it into the law and the practices of our institutions. So we did the exact opposite of what the Ottawa Charter was saying to do, salutogenesis, healthy communities, healthy cities. And not only did we do it, there were segregated telephone booths in Oklahoma, telephone booths. Not only did we do it, but periodically we would engage in just overt terrorism to enforce it, to burn people out of their communities because they were perceived as being successful despite all of this. So it's not like we just missed the mark. We went to the other side and designed communities that were intentionally defined by their distance from opportunity for African Americans and for Native Americans. When I went to Johns Hopkins Medical School and walked around East Baltimore the first time, I grew up in Canada, which you're going to hear about in a second. This is what I saw, and I couldn't understand for the life of me what I was looking at. And I couldn't understand how this kid, who for all intents and purposes is me, was expected to navigate this environment every single day of his life and not be impacted in his health and well-being and his future outlook. I didn't understand it. I still don't understand it. It was the moment of seeing that and wondering when somebody had dropped bombs on the place that changed my life trajectory, and it has me here today. I'm still trying to figure this out. I'm still trying to figure out how can we construct a society that creates environments like this where this kid has to figure out how to get from A to B every single day of his life, knowing, because these kids are not stupid, he knows that he's being devalued in this society. And he's internalizing this, and it's causing all kinds of physiological changes in him over his life course. We've done this intentionally. Example after example, I took out a bunch of slides, again, because of David. This is Detroit. We built a wall between white and black communities. So there's no question that this was intentional. This Native American, the conditions in reservations all across this country, but in California that I saw with my own eyes without running water, without electricity in the 2020s in California. We did this intentionally. Okay, so how did that manifest itself? Well, I and some others decided we wanted to draw some maps. So we pulled a bunch of death certificates. We calculated how long somebody could expect to live in their neighborhood. In Alameda County, there's a 22-year life expectancy difference between the Oakland Flatlands and the Oakland Hills. And the stunning thing about this is a stable gap. It's actually gotten a little bit worse. People said there was something weird about Alameda County, so we started going around the country and working with health departments to do the same analysis. This is Baltimore. Ended up on the front page of the Baltimore Sun. In Baltimore, you had neighborhoods, when we did this analysis, with life expectancies of 58 years. And other neighborhoods up near Roland Park of 90 years. Same thing in Cleveland, Cuyahoga County, New York City, Seattle, King County, LA, Minneapolis, St. Paul, Boston, Philadelphia, San Antonio, Denver, Cincinnati, St. Louis, Chicago. Everywhere we looked, we found these fixed, growing gaps in life expectancy between neighborhoods in the same city, some adjacent to one another. This is the American pattern. This is the status quo. It's deeply entrenched, and it's a legacy of slavery. It's that same lineage that creates these realities that we have to negotiate every single day in the modern world in the United States. Okay, so that's just the first section. The second section is really about, okay, so what's the role of government and our organized efforts to try to undo some of this? How do we create those conditions that that young child needs to be able to navigate successfully a healthy life? And this gets back to a very fundamental agreement between government and the governed, which is a social contract. And the Declaration of Independence, I mean, if you read it, it's actually kind of a funny read because it's like literally a list of grievances. It's like, you did this, King George, and you did this, and you did that, and because you did all these things, go to hell. I mean, that's basically what the Declaration of Independence is. And it cites these kinds of this basic kind of continental philosophy, which was that humans left to their own devices are basically kill each other. And so we have to make these kinds of organized agreements about how we will live together. And one of those is that in exchange for our consent to be governed, we expect government, you to deliver things that essentially improve our life, liberty, and access to sort of health protective resources. That's my word. And so that's what the social contract is. It's like, I will give you a few of my rights, but not all of them, and I will let you sort of organize resources in a way that benefits me. But the minute you stop doing that, I reserve the right to overthrow you. That's what the Declaration of Independence says, and that's what a social contract is. And social contracts tend to be strengthened after times of trauma. It's really, this is the history of sort of the modern world. When you look at post-World War II in Europe, after Europe was basically carpet bombed, you see these social contracts sort of emerge and get strengthened. And one of the, well, I'm going to tell you in a second, there's some clues about the strength of a social contract. The lesson that the US took post-World War II was not, that we need to strengthen our social contract. It was like that we can basically dominate the world. We're great, our industrial might is great. Let's just stick to what we're doing. Europe took a very different lesson. Okay, so I grew up in Canada, as I think I mentioned, and Canada has a very strong social contract. It's got universal health care, universal dental care for kids, it's got universal child care benefits, universal, if you will, paid sick leave and vacation for all employed Canadians, state-of-the-art public transportation in most of the cities, highly subsidized post-secondary education. I went to McGill University for free. In fact, I got paid to go there. And then high-quality community resources, invested. I mean, some of the community centers in Toronto, where my mother lives now, look like country clubs. And I'm shocked that I'm like, this is a community center? I mean, there's like an indoor sort of pool here and a water slide, and I only have to pay 50 cents to get it. Anyhow, if you want to assess the strength of a country's social contract, just look for one word. And that word is universal. And that's going to be one of the themes of this paper, is like, why does the US not have universal policies? And I'm going to tell you. So what's the American social contract? And sometimes I pause and I ask people, what is the American social contract? Because I really don't know. I mean, like, what is it? What's the agreement here? It seems like kind of like, everything's been tossed in the air, and it's like, it's might makes right. Is that the social contract, or money wins? I don't know what the agreement is here, the fundamental agreement. I suspect some of you have some ideas, but the U.S. doesn't have a lot of universal policies. All right, we don't have universal child care. We don't have universal paid leave. Even with COVID, we couldn't make that one stick. The Build Back Better, we couldn't make it stick. And we certainly don't have universal health care. And when you start seeing patterns in public health, you start to have to ask yourself questions about, well, what's causing these patterns? Why are we one of the only developed countries in the world that doesn't have these fundamental universal policies? Why didn't we build out our social contract like the rest of the world did post-World War II? Now, in the Depression, Franklin Roosevelt tried with the New Deal. I mean, he might as well have called it the new social contract. I don't want to get into a lot of history here, but a lot of what was left out of the New Deal were policies and policy strategies that could have benefited blacks, very intentionally. And that's a little hint to why we don't have universal policies, why our social contract is so weak in this country. It's racism. I mean, it's fundamentally, in order to have a strong social contract, you have to have social solidarity between groups. You have to be able to see other people's needs as your needs. And the minute you say, I have needs, they have needs, but I don't want to fund their needs, you lose that social solidarity. And once you lost that social solidarity, you can't engender the political will that it takes to invest and support in universal policies. That's our challenge. And that's the nut that we're actually starting to crack in California. Because we recognize that narrative, the story we tell ourselves about who we are, the values that we hold sacrosanct, drives policy. And policy creates conditions. So if you want to change the conditions, you have to change the policies. If you want to change the policies, you have to tell a different story about who we are. And that story in California, the story of we as Californians, is starting to take hold. And it's changing the policies, and it's changing the conditions. We struggle now, with this. The previous president was a pretty expert narrative, orator. I mean, I don't know if it's just luck or he was more clever than we ever gave him credit for, but he took on narrative, an exclusionary narrative, which created essentially exclusionary policies in a weak social contract and very adverse conditions when it comes to public health. But he understood that connection. And I don't think we understand it so much in the health policy space, that narrative shapes policy, policy creates conditions. Okay, so that's why we lack universal, at least that's our theory as to why we lack universal programs in the United States. And then and people have written about this isn't, something that we came up with. We create policies where we use a charitable model, where we basically say that there are poor people that need, some sort of mitigating strategy, but we don't want to necessarily extend our supports, except for in some instances, to the entire population, because we like to stigmatize. We like to separate and we like to stigmatize. And, we make these programs so that people have to constantly re-up, constantly prove their eligibility. They're churning all the time. I mean, we had an opportunity to create universal health care. We decided, no, we're not going to do that. We're going to create Medicare for, worthy seniors and Medicaid for unworthy poor people, read Black people. And, that's the model that we have. And they're going to pay differently, and they're going to be structured differently. I mean, this was the American solution to universal health care. Okay, so when you lack social solidarity, you don't get universal policies. That's the bottom line. And the goal of the work at the community level is to change the story to create a larger we. If you can create a larger we, which we have in California, we continue to do this, is ongoing work. Somebody said it earlier, this takes work. You can create a larger we, you can create that social solidarity that's necessary to get political will for universal policy. So let me just show you a little bit of data here because I happen to like this data. This was done with Steve Wolf at the Virginia Commonwealth University, which is around the corner from here somewhere, I don't know where. East Coast is all the same, you know. So this is just a, you know, it's sort of a very rough social gradient. So this is on the y-axis, the up-down axis, you've got life expectancy. On the x-axis, you've got household poverty. And so as you move from left to right on each of these graphs, you're moving from relatively wealthy neighborhoods to relatively poor neighborhoods. Each of the dots is a census tract. And we just wanted to correlate life expectancy and census tract and poverty. And in an ideal world, this would be a flat line, right? How poor your neighborhood was wouldn't predict how long you live. But we don't live in an ideal world, and there's a cost to living in a poor neighborhood. So we calculated that cost for California counties, and this scattergrams is a collection of large California counties where we just wanted to look at the slopes of those lines, because a flatter line suggests more equity, a steep line suggests less equity, and there's also another correlation here, which is that the steeper the line, the lower the line is. In other words, everybody's well-being is brought down by inequity, and the flatter the line, the higher it is. And I said, well, let's compare those to Canadian metropolitan areas. Roughly the same size, and let's just do the same analysis. So we worked with some public health researchers in Canada and did this analysis, and you probably can't see this, but these are major Canadian cities. And just to simplify this, up top you've got the California counties, the aggregate. On the bottom you've got the Canadian cities. So again, I say in public health you don't have to be a rocket scientist, but you do have to be able to spot patterns every now and then. And there's something going on here. As you move from relatively wealthy neighborhoods in Canada to relatively poor neighborhoods, you don't see nearly as much of a cost. You don't see that social cost of living in a poor neighborhood because Canada buffers poverty with its social contract. You can live in a poor neighborhood in Canada and still have health care, still have childcare, still have paid sick leave when you get sick, still have access to transportation, still have subsidized education. So this is what a social contract is. It anticipates people's needs and builds in those buffers. Canada does this. We're doing a similar study looking at some Western European countries. And for those of you who are curious about some other American cities, we've done a few other American cities. So you can pick your city. We're always happy to do it. I doubt we're going to find anything terribly surprising, but I'd like to be surprised one of these times. I really would. Okay, you've seen this data before. I just throw it in there because it's going to be in the paper. This is per capita spending on medical care across OECD countries. We've all seen this. Whenever you put the US on the graph with everybody else, you've got to change the axis because we literally spend twice the OECD average. That's not that interesting, but Bradley and Taylor did this much more interesting thing where they took that same data that's now in the blue and they added to it per capita spending on social benefits and services. And they found when they did that the US is not the big spender. We actually don't spend more than others. We're just dumb with our spending. I mean, we literally are just stupid. So we spend disproportionately on downstream medical care and we underinvest in social services and benefits. That's the social contract. We underinvest in our social contract, and therefore we pay the price downstream. And what Bradley and Taylor showed in their, which originally, this is what Lauren Taylor told me, they originally published this as an op-ed in the New York Times, and it got so much attention that they actually wrote a book. And the book is basically what was in the op-ed, which is that for every dollar spent on medical care in developed countries, roughly $2, twice as much is spent on social services and benefits. In the US, it's only about 55 cents. So we literally have the accent on the wrong syllable. That has nothing to do with us being stupid. It has all to do with racism. It has all to do with racism. We just do not want to invest in our social contract. And it's Bradley and Taylor. And there's collateral damage to racism. And that's what deaths of despair are. It's essentially unintended victims of American racism. And this is what Angus Deaton and Ann Case showed. This is just mortality rates now, looking at a whole host of different populations, and that bright red line is US whites. And there's been a lot of study, this has gotten a lot of attention. I don't understand why when economists publish this stuff, it gets on the front page of the New York Times. But when public health people say it, it's like, yeah, whatever. This is the lack of a social contract. Okay, last two sections quickly. How do we design healthcare services that strengthen the health assets of differing populations and cultures? This is, I think, the biggest challenge. In Alameda County, we have probably the nation's best network of community-based health centers. We have Asian health services, we have La Clinica, we have several centers that are focused on African-American health, centers that are focused on homelessness. They're very culturally competent. But the demographics keep changing, and trying to keep up with these various populations in these different kind of configurations is tricky. So we're trying to explore those efforts that have the most interesting core principles to them in the paper. We're working with California Pan-Ethnic Health Network, or CPEN. They did a series of focus groups with different cultural organizations across California over a 2-year period, and came up with these core principles that they think are critical to designing a healthcare system that leverages community assets. I'm not going to spend a lot of time on this, but there are two models we want to delve deeply into. Don Berwick's name has come up a few times. He came to our board at the California Endowment, and he talked about the NUCA model, and it kind of blew my mind that this was something that exists up in Alaska, and I had an opportunity to get up there and get a look at that, and I think it's one of the most brilliant designs, and it was sort of happenstance that they actually had the opportunity to do this design. There's also a program in Hawaii. It's kind of interesting that the most interesting ones are in Alaska and Hawaii. KKV, the Returning to Our Roots program, which is really also focused on indigenous Hawaiians, Native Hawaiians, and sort of handing over the control of design of health services to the population most impacted. These are two programs, and there are many others, that are really taking this concept of patient-centered medical homes and taking it much further than just sort of the patient at the center. It's really the community at the center. And then finally, the last section is really how do we actually flip the script and change governance and accountability so that the communities impacted are most responsible for how resources are allocated in health systems. I wrote a paper with Bob Ross and a colleague, Pritpal Tamber, recently in Health Affairs about essentially how to build community power and how it makes a difference. And fundamentally, that power is the governing power that we need to enhance in order to create equity. This is not going to happen Damon talked about it a little bit. This is not a technocratic enterprise. This is a democratic enterprise. And I think that that's the key mind shift in this work, is that we're not going to solve this at the margins. We have to rebuild our social contract. And to do that, we have to create a stronger and more vital inclusionary narrative that allows us to build the social solidarity and political will to invest in universal strategies. And those universal strategies will create an even playing field, not just for African Americans, Native Americans, and people of color, but for white people. And we have overwhelming evidence about this. There are a number of leading thinkers working in the space of what it takes to create a multiracial democracy. Race Forward is one of them. They have a very thoughtful analysis where they've actually gone around the country and talked to some of the most thoughtful practitioners in this space that are trying to reshape and flesh out this concept of co-governance for a multiracial democracy. There are wonderful principles that they're working towards. We hope to touch on them in our paper and get to the heart of the governance issue, which is still something to my mind which is given short shrift in these conversations. We don't think about, at the end of the day, equity isn't something that's going to be achieved on Tuesday, March 31st, 2074. It's a constantly dynamic process. It's a constantly moving target. We're all going to be working towards this for our entire lives, as will our children. And the goal is to aim for that perfect system, but we'll never get there. But that process of aiming and working towards it is going to create enormous changes and outcomes that are equitable along race, and along class, and along geographic where you live. So let me stop there, and thank you very much for your attention.
All right, so as you can see, we are beginning to lay out the vision for what this equitable healthcare system looks like, even as we're talking about more incremental strategies to help address the needs of populations that are in need. I'm going to invite our next panel to come up. We're going to begin to talk about one of those issue areas, which is technology. And as we know, technology is here to stay in our healthcare systems. We are moving toward spaces and places where clinicians have diagnostic and clinical decision supports, but we've got to ensure that that technology is harnessed in ways that advances equity and doesn't continue to replicate existing inequality. I'm going to invite our next panel up, which will be led by Dr. Joe Betancourt. And as our panelists come up, I'll go ahead and introduce them. Our first panelist is Cincy Hernandez-Cancio. She's Vice President for Health Justice with the National Partnership for Women and Families. To her far left is Amina Mosley, Manager of Community Organizing at Vital CXN. And to Joe's immediate left is Dr. Carolina Reyes, Associate Physician, Maternal Fetal Medicine at UC Davis Medical Center. And last but not least, third from Joe's left is Dr. Anna Zink, Principal Researcher at Chicago Booth Center for Applied AI. So please join me in welcoming this panel.
Great. Thank you all. Appreciate you being here after lunch. Thank you, Tony, for inspiring us with just really provocative, I think provocative concepts, really, really critical. So I appreciate you and thank you for that. So I had the great pleasure of hosting a discussion that we hope will engage you all. Please, you have QR codes there. If you have a question during our conversation, please jump on the QR code. I have an iPad here. And, you know, questions are going to show up here whether you all put them in or not. So I'm just going to tell you, put them in, and we'll have, I'd like to take real ones, which is a good thing. You all know how we do this. So let's bring me some real questions. So I wanted to open up just kind of a little stage setting our conversation. You've heard about our panelists really is focusing on technology, pros, cons, challenges, opportunities for advancing equity. So there's no doubt that as we look over the last few years that technology is developing and advancing faster than ever before in healthcare. And the pandemic certainly accelerated the use of technology. So whether we think about the pressure that the pandemic put on the acceleration of virtual visits and telemedicine, whether we think about the new kind of evolution around wearables and the need for kind of hospital at home and home monitoring. Also, as we think about the ongoing evolution of clinical decision support, whether it be machine learning that allows for diagnostic precision in complex areas such as cancer, endocrinology, nephrology, artificial intelligence, which, by the way, all my questions were generated by ChatGPT, in case you all were curious. I entered them in, so these are all fully generated. But all kidding aside, AI now showing even better results in being able to read mammograms and CT scans. Clinical algorithms, which I think are going to be a conversation of concern. Very influential, an important paper called Hidden in Plain Sight a couple of years ago in the New England Journal of Medicine, talking about all the ways in which race is baked into a variety of different clinical algorithms. And certainly with every opportunity with technology, there's certainly a challenge for vulnerable populations. So whether it B, the fact that we know that technology has a 5 to 7 year lag as it gets to communities of color. We also have understood the benefits of technology. So when we think particularly around mental health, there have been 3 major barriers that have impacted communities of color. One is stigma, one is the social influencers being able to get to a place, and the third is being able to see a provider who speaks your language or understands you culturally. You know, virtual visits can solve all 3 of those. Privacy of your own home, addressing stigma, virtual, not needing to go anywhere, and you being able to connect to a provider in another state or another area that speaks your language or looks like you. But on the same side, we see the challenges that include the digital divide. We understand that technology lag. And, you know, COVID gave us yet another example of how life-threatening these technologies can be if not tailored correctly. You all may be familiar with a study that showed that pulse oximetry, our way of measuring oxygen through a small device on the finger, was highly flawed as it related to its ability to be accurate in darker skin. Yet I and others in the healthcare space during COVID, were literally using O2 sats as a predictor when we might move somebody into the intensive care unit. So today, our opportunity is to consider what are the pros and cons, what are the benefits of technology, particularly as we think about disparities in health equity. And we'll have a chance to delve into what I hope will be a variety of these different areas, because these areas, obviously ChatGPT is I said it as a joke, but that thing, my son introduced me to that, on his computer, I feel like 8 weeks ago, and now what we see is incredible. So this stuff is here to stay. It's moving fast, and we really need to think about our voices in that process and equity in all that occurs. So we'll get a chance to hopefully talk about virtual care, wearables, monitoring, machine learning, AI, algorithms, diagnostics with this esteemed panel. So I want to begin with just a very basic question for each of you, and it's going to have a couple of parts, but I want to make this a bit of a conversation. So Carolina, I'll start with you and maybe just make our way down. Do you see the promise in the use of technology to achieve equity? As you hear about these things, I mean, do you see promise? I gave one example of mental health, but in your field, in your work, kind of big picture, what is your gut telling you?
A huge picture. I agree. I think there's a tremendous promise, and as you mentioned, we've seen it most strikingly over these last years. Telehealth, for one, connecting with families, especially where they are, especially women, and in my field, in maternal child health, I deal with high-risk obstetrics patients. Many of them have children at home. So to be able to access or have a visit with them in their home through telehealth has really meant volumes. Listening to them, seeing them, and being able to hear their questions, but also getting a glimpse of where they live, I think has helped tremendously. Everyone has a cell phone. And what I've seen over my 20-year experience in healthcare in dealing with women who are pregnant, that they come in with questions already, right? Because there's so much on social media. The key is targeting the accurate information to these individuals. So is there tremendous opportunity with technology? Absolutely. But we have to recognize that it's one tool, only one tool, because it doesn't replace that individual conversation with that patient and knowing that patient. And we can go on, but I'll let you talk to others.
I appreciate that, and I think that's exactly where I want to go. Cynthia, I'm interested in your thoughts here, the promise of technology for equity.
Well, I think that technology, like pretty much everything else, and especially in what we have seen through COVID and beyond, just a reminder, you all know it's not over. People are forgetting that it's not. Is that there can be plenty of promise, but there's also incredible peril. Because we are already starting with a very unequal playing field. And I ask for grace because I have long COVID, and sometimes my words fail me in 2 languages, which is especially frustrating. But there is no social contract for broadband. And the way we even measure access to broadband, the digital divide, is based on whether there is in a county any broadband at any price, right? So those maps that you see that the FCC puts out are very inaccurate about what the on-the-ground reality is. So yes, people may have cell phones, but we saw this impact thinking about social drivers, not just in your ability to access health, but in children's ability to access an education. right? We heard the stories of school buses that were putting hotspots and then driving to neighborhoods where there was no where there was no access. And so the idea that we could build solutions, to, silver bullet kind solutions to health equity based on telehealth, we need to be very, very skeptical of, because the infrastructure isn't there. It also is not particularly helpful. I have a brother who's a clinical psychologist, bilingual, culturally centered, Puerto Rican guy who can now do telehealth for, populations that otherwise would not be. But he doesn't have enough hours. We can't be exploiting the few that exist. There's just not enough of them to go around, and that is not solved by telehealth. And then the other thing that we're seeing, especially when it comes to the women's health space, is the incredible and frightening impact of social media and even how people are using apps to track things like their menstrual cycles that can be used against them when we have so many states right now where access to abortion is illegal. And we saw horror stories of people being prosecuted and even doctors being prosecuted based on social media posts and what people were asking about one-on-one on Facebook, right? So lots of promise, but again, if it's not built, and here I would say, let's think about the idea of targeted universalism. If it's not built to ensure that the barriers for those who have the most need are met, what we're going to end up doing is reifying and deepening the inequities that already exist.
Yeah, and there's countless examples already in the literature of ways, I mentioned the pulse ox is one, that's a device, but even some algorithms that are used for the provision of care management.
Absolutely.
There's been a bunch, and there's probably a bunch that we haven't discovered. So
because at the end of the day, it's garbage in, garbage out, right?
Yeah.
And that's what we're seeing when it comes to AI and those kind of algorithms.
Yeah, I appreciate that. Anna, your thoughts here, what is the promise of technology and equity?
Yeah, I think there's ways we can interpret and learn from data that we couldn't before, from images, from eye scans, et cetera. And I think there's opportunities there to kind of change the workflow of doctors, hopefully in a good way. AI is very good at doing things well, quickly, and hopefully at a low cost. So maybe there's certain things that you don't like to do that they can help assist with, and so you can focus on the things that you'd rather do, like treating patients. We joke about ChatGPT, but I think it's changing the way a lot of people work, hopefully for the better and maybe sometimes for the worse. And so I think there is a lot of opportunity there to learn new things. When we look at an actual X-ray scan, what information is in there? Are we using all the information that's available? And what else can we learn from it? And so I think there's a lot of opportunity for learning, but yes, you need to be kind of very thoughtful about how it's being used. And in terms of predictive algorithms, the data, there's this idea, sort of a fleeting idea, that data is neutral, but if all of the data is collected in the system that you're living in, then all the biases that exist are just going to be perpetuated through that. The data that you collect depends on who goes to see the doctor and what they decide to code, et cetera. And so that's what creates issues when you're trying to sort of blindly create these predictive algorithms.
And do you think we default to, when we see new things, that, oh, this has got to be bad? I think a lot about this. I think every generation looks at the generation before them and says, oh, that hair, oh, that music, oh, they're doing this, right? That's almost a default. I think about it in medicine a lot. So, we used to have to listen to all these recordings of heart sounds. I still use a tube to listen to the heart with a stethoscope, where now we have kind of devices that could literally just tell me if you have a murmur and if your heart's functioning well, at the bedside. Or, the complex assessments of renal disease, where you have, 12 different electrolytes, and this one's up, that one's down. And so, I think of the incredible benefits of the ways in which my mind can be decluttered around and then do more of the caring part. But I feel, too, this kind of resistance as well to change. I
think the speed is a little scary, just kind of rushing forward without feeling like things are properly tested or how they're actually going to work out live. And so we're still learning as that happens and making sure we're collecting the data and looking at the right outcomes to to know that. And I also think naturally people will stop using the things that aren't working, and hopefully there will also be some people kind of overseeing the technology as well to make sure in the areas where we're not looking that someone knows that maybe it's not working as intended.
That's a great point, because speed, I think, gives people pause, especially when we think about equity. Carolina, you wanted to jump in real quick, and then I'm going to go to you.
Again, as a clinician in real time, yes, it's very helpful to have calculators, right? Or to have information right in front of you that will help you guide. But again, it's about what goes into that data that comes out. And in real life, for us, we know that certainly when we counsel patients around a vaginal birth after cesarean, can they successfully have one? Using African American was part of the formula that decreased their success rate. And in looking now at a paper we did where we, in Northern California, looking at the data, was there really a difference? Not too significant of a difference. And then when we look back, again, you have to think about what goes in. And so when we look back at why was that put in there, there really wasn't enough justification. And now we realize that in many respects, we were counseling patients that they had a lower rate of success than somebody who is not African American. And so we don't use that anymore. There are other types of criteria, but I think we have to be careful with what we're using. In the end, it really is about, I said that one-on-one. I wanted to use the example of our depression screening. Depression screening, high risk of depression, patients get pharmacotherapy. And I wanted to use an example of a colleague of mine who's a psychiatrist who works and provides counseling to university-based students, getting many of these young kids, young students counseled around depression. And she looks at them and she says, "You're not depressed, you're just malnourished. And you don't eat enough." And realizing that it's not about the score, it is about figuring out that individual patient. So in many respects, we have to be careful with the tools that we use. They're tools, as I said, they're very valuable tools because they do expedite much of what we do and help in terms of our documentation, but we have to recognize that it's one tool, and you cannot undervalue that one-on-one experience with the patient.
Same question to you,
Yes, so just to provide a bit of context around myself and the job that I do. So I grew up in Boston, Dorchester, immigrated from Jamaica. And so I came into this landscape of not realizing I was Black and entering into a space that I became Black. Also this intersection of being an immigrant. So I grew up here, and I wanted to really say this on this stage because it's one of the scariest places, I think, to say it. I grew up in this country undocumented. And so this intersection of being Black, a woman, and undocumented has helped me to see a lot of the gaps that exist because I lived through it. And so in this conversation, I really want to add to a discussion about how can we use technology in the community space and to translate information from centralized spaces such as hospitals that use technology, I think, more frequently than in community-based settings. How can we have translation of data happen in a way that's actually accessible to community members? Sometimes data is, I work a lot in professionalized spaces, what I get to call it, traditional professionalized spaces, and it's easier to engage with that data because you go through years of school of how to understand it. And for community members who don't sort of have the time, because they're doing so much more, they're doing their full-time jobs, and they have to come back and sort of understand the language that's being shared and the data that's being shared. So how can technology help to improve that? But how can technology help to convene clinicians and community members in a way that separates this? I've seen this sort of conversation in other panels of this top-down, right? We have all these resources here, and it's coming to community members. We're bringing them out into community members, but really it's a shared experience. And how can community members be active players and active decision makers in that space? And I think that technology plays a huge role. And we've seen it during the pandemic of Zoom really being used to convene people and how to have systems of accountability, but also for asset mapping. And so one of the amazing apps that came out recently was from Vital Village, from Boston Medical Center, the Abundance app, that you can see all the food distribution sites in your area, and you can see which one is active, which one's nearby, and it's updated regularly. And we have something similar from Vital Connections as our food resource app. And so community members are able to easily access these resources and sort of stop seeing their communities as resource deficient, because there's a lot of talk about there's not enough resources in the community. But I can say in Boston for sure, which is the mecca of healthcare, that there's huge amounts of resources, and there's amazing access to technology that's just not being translated or brought into the community in a meaningful way. And though there's huge opportunities, I'm a bit cautious to be all in, and that's because it's lacking community voice. And meaningful engagement, which means that communities have to be co-designers. Communities have to be the point of accountability, and so you're constantly engaging with communities in the same way that, unfortunately, nonprofit organizations that support communities are, accountable to responding back to donors. It has to be in the same way that institutions, academic institutions, health systems are saying, we're going back to the community as a whole to be responsive and actually be accountable to that. And also for capturing feedback. And so once whatever's created, co-designed together is created, then we have to see if it actually works. And that means showing up. So you can't just create the technology and then saying, oh, this is a platform, we can convene people. And it really has to be a skeleton, right? It can't be, I like to look at technology as like a blank canvas. And community members have been really scrappy to pull together different platforms, such as Facebook and Zoom. And I saw amazing work done by the Boston Center for Independent Living that tracked different experiences across health centers in a Zoom call and put it on an Excel sheet, and that's technology, right? And so capturing that feedback is really important. And because community members have to be so scrappy, and because it's sort of prescriptive, the technology is very prescriptive, there's no room to sort of play around with it and actually make it work meaningfully for them, and not just working with like bare bones and working with like threadbare, like just the bottom of the barrel, and actually have a really substantial material to work with. And so that's something I really want to push forward in this conversation, is not just thinking about what's possible within healthcare settings, but what's possible in community and the impact of working together and what's actually possible when we work together.
That's a great point, because I for years I would always make the case to tech companies that they could get their biggest return on investment in communities, particularly where conditions are, disproportionately impacting those communities. So diabetes, for example, you create an app that moves somebody, 1 point on their hemoglobin A1C, but in communities that are disproportionately impacted, that same technology could get you an incredible return on investment. Do you feel like, in your experience, the NIH is able to kind of create some mandates around clinical trials, but in the tech free market space, there's no kind of requirement to go into to say we're going to do it in a certain way. Do you feel that happens, or do you think there's a need for that to happen?
There's a need for that to happen, because I generally don't think it's happened. I haven't heard of any examples where, and not just for having access to the tool. I love the example of using it as a tool, because I'd like to stress that technology isn't going to solve any of the underlying inequities and structural racism that exists. And so there has to be a period of redress. And because we're not doing that, because we're not acknowledging histories of inequity, then actually pulling from that space. Because when I think about opportunities coming from tech, I also think of employment. And when we think of employment, we think of economic mobility. And it's sort of from a space of like, there's no, from what I've seen, I might be wrong, there's no active or intention around bringing these opportunities into the community, aside from sort of tell us if it's working. And so it's this consumer dynamic, is we have a product that we're selling, so let us know if it works for you, because you have to engage with it for us to make money. But not rather of, we understand that your engagement within this product and your help in building this product is important and necessary, and so we have to engage with you as an equal player. And it's not this, again, not this hierarchy
Yeah.
of here comes the resource.
No, I appreciate that. Any reflections? Yeah, go ahead.
Yeah,
Kristen.
'cause I would say that the challenge is that healthcare and these tech companies are organized around a kind of a wealth and resource extraction model, right? Not in providing a public good necessarily. And I know probably a lot of doctors in this space, and that might be a little, disruptive. But at the end of the day, you mentioned, what probably the worst 3 letters in the alphabet, ROI. And as long as ROI is driving decisions of how resources are distributed, then we're not going to see a way out of this. There is no capitalist solution right now to inequities. And for us to think that the way forward is to make taking care of poor Black and brown people profitable, that's an alternate universe that I, would love to live in, but that is not the experience we're having right now. And so that is a challenge. It is what Tony was saying about there is no as I said, no common good here. There is a corporatization, an increase in wealth inequality and income inequality that is worse now than it was before the crash 100 years, more than 100 years ago. And so we cannot expect that the solution is going to come from a completely unregulated, Wild West corporate situation that we have right now in the healthcare system. And what we're seeing is that it's becoming even more concentrated, more consolidation, and the more that happens, the less there is the ability for communities to be part of co-creating any solutions, because it is not cost effective. That is why there is no broadband in so many of our communities, because it's not cost effective. If they can't, if AT&T or I don't even know who does broadband anymore, but whatever those companies are, if they don't find it profitable to add another mile of cable, they're not going to do it. And that's why we see that it stops in certain places.
Yeah, no, that's a great point. But, I think
And we can't hope, and I'm sorry to interrupt, we can't hope that there is accountability.
Yeah.
We have to build it.
In Boston, there's an example now, and actually at the federal level, I believe as well, incentives around extension of broadband. So, I think there is a role, or I see some action happening, but your point is well taken. Carolina, you want to jump in.
Well, you begin with what you have, with who you have, right? And in many respects, this is where I think philanthropy has played an important role, and the community voice has played an important role, because we recognize that, yes, technology in healthcare is here, and it's thriving. And it's how does that technology can that technology benefit services within communities? So this is where philanthropy, like California Healthcare Foundation, works with their innovation fund and reaches out to those companies and say, our mission is to help the underserved. You can help benefit this community by bringing your technology here, but with these caveats. That your planning requires listening to that community, that you provide your technology with multiple sources, multiple languages, and understand the culture of those that you're providing that care to. And so in many respects, this is where, again, with what you have, you begin to work with these companies, which is what California Healthcare Foundation does, brings them into that community and says, we'll help invest in you, but you have to have this kind of criteria. Now, it's not the answer, but it is the beginning of helping connect that technology to provide a service to help address some of that inequity.
I appreciate that. And I want to turn to you. Well, did you have a reflection on? Yeah, please go ahead.
I was just going to say, I think there's a similar analogy to the drug space, and having incentives in place to put research into certain conditions that might not otherwise be funded and so on. And I think of tech in a very similar light. We need to direct money in the directions where we really want there to be problem solving and solutions.
That's a great point. And sticking with you, Anna, for a moment. So, there's no doubt that, as we said, these things are here, they're growing, they're moving fast, they're here to stay. As you think about this work, and we think about the biases that happen from lack of participation, what are some ways that you believe this, your work can help detect and root out bias? And so what are some of the preconditions we need to set before launch when things are moving so fast that can help address some of the concerns that we mentioned today?
Yeah, and so there's a lot of different types of AI or tech, and so I think the solution is a little different depending on what area you're thinking of and who's actually using it and developing it. I know in health systems, there's like a lot of governance boards are creating new subcommittees or new kind of discussions around how to actually monitor and evaluate AI that they're planning to bring in. So like, what are the things you actually, if you decide you want some tool that you want to use, like as it comes in, what are the things you're actually going to look at to make sure it actually works well in your population? Are you going to have silent monitoring to see what it would actually suggest for patients that are coming in before it's released? And so I think these standards are starting to be established so that from the technical teams who are working on it to the people who are overseeing whether they should purchase one of these products, what they should be asking and thinking about before they just kind of release it into their patient population.
Do you think launches are happening too fast and there aren't any gates there to address some of those concerns?
I think there's not as much data in terms of, or that at least that I know of how much it's actually being used. I think there's a sense that it's everywhere, but then also you sometimes talk to different people and it sounds like they don't feel like they're using it that much at all. And so I think there's also a lack of data in terms of what do we know what people are using right now? I don't think there's a list or some data graphics so we can compile the list of algorithms that are at play and what's good and wrong about them. And so I think a better inventorying of the problem would also be helpful at the same time.
Yeah. So Carolina, as you think about how equity can inform tech efforts, I mean, what are some 1, 2, or 3 things that come to mind for you?
How? One is who's at the table, right? Designing that technology. So this is where, again, you work with what you have. So right now I work with California Healthcare Foundation to help bring that to the forefront and ask who's helping you design this technology.
Yeah.
And in terms of who you're designing it for. So that should be a requirement in terms of who's designing it. To what extent have they listened to that community to understand what the needs are, as opposed to that top-down approach, this is what we think you need. And making those requirements. We're reaching out, though, even further. It's like those that are investing in that company, who are those investors? And are you are you looking for money managers that are of underrepresented communities to help invest in that funding? And again, this is where we have that opportunity to ask those kinds of questions. So I think it's about who's designing it. Because once it's designed, it's very difficult then to, again, it's what goes in terms of making it useful for what comes out. I would say just briefly that would be one example of making sure that the right people are designing it and that we're bringing up mentors. We're finding mentors that help sort of those that are younger, mentoring them to be part of that process.
Yeah, we in my previous role, we're using kind of young people as kind of tech advisors for older people, getting them on the electronic health record. Big gaps, big disparities in who's on the electronic health record, and so leveraging kind of youth opportunities to kind of help people navigate just getting on. Do you see in your clinical work stereotype breakers? By that I mean, individuals who come in who I think many people would say, they'd never be able to navigate that technology, who are navigating it very well.
Oh, yeah, absolutely. I think, again, it's listening to that patient. It's very easy to, sometimes we have, 15 minutes with a patient. And it's very easy to make judgment calls and then tailor that discussion, right? But it's breaking that barrier is really changing the narrative in that you're asking a question to that patient, an open-ended question. And it is amazing how those judgments sort of fall to the wayside because you're recognizing I didn't see the person in front of me until they started talking. So in that respect, yes, that there are ways in terms of helping break some of those barriers, but that is, I think, it's listening to the patient.
Yeah, I would argue even in tech, I mean, sometimes you people come in the office who, older Spanish-speaking woman who's banging her way through an iPhone and has all her data and has all this other stuff, and you'd say, I think sometimes we make assumptions that, certain communities can't learn, and so why invest when in fact we see that.
No, they're very bright. And, I find, I think it's true, some of those, I know it's true, those studies showing that if the individual, the clinician that's in front of them, if they can relate to them, whether it's that they're a woman or they're a person of their community, et cetera, or of their faith, they open up. I have to tell you, when I see patients, and we know we deal with patients with multiple languages, and we didn't use interpreters like we do now. But bringing in, even if it's an interpreter through a video, because there's so many languages, when I first start to talk to the patient, they'll just kind of nod yes or no. But when that interpreter begins to ask that question in Urdu or Farsi, oh my God, I have to give another 20 minutes just to hear them out. And it speaks volumes to just listen to the patient in the language of their choice.
I appreciate that. So, Penny, I wanted to get a sense of your kind of some wins that you've seen in the community with technology. As you in your work, are there one or two or three things that really jump out that serve as kind of promising practices or things that you think could inform where we're headed?
I think the Abundance app that I mentioned before is a huge tool that's being used in the community right now. And the example that I gave before about Boston Center for Independent Living and tracking of experiences across different health centers. But I think that the learning that we can take from the community in response to technology happened during the pandemic, and their use of platforms such as Facebook and WhatsApp to mobilize to support their communities. And so what we saw during that time is, and I really want to state that the solution already exists. It's happening right now in the community, because I think what's missing here is that we think that it's an unequal space, and communities are suffering, but they would be doing worse off without each other. And so what we saw during the pandemic, when people didn't have, if they were undocumented, they didn't have funding, or they didn't get stimulus checks, or didn't get any of the tax breaks, or they lost their jobs, or they were experiencing unsafe work conditions where they couldn't get masks, or even during the death of George Floyd, and they wanted to mobilize. That happened on social media. But then also another amazing thing that happened that I felt like I wanted to share here too is that the idea about technology being a tool and being a blank canvas is that what's needed from the technology is different based on the community. So for people looking to mobilize and come together in response to getting connected to food or getting connected to a new employment opportunity, which during the pandemic, when I lost my job, I got my job off Facebook because community organizers came together and tried to support each other, that's one need. Convening and connecting is another need, but also security is another need. So undocumented people coming together and sharing their experiences is a very scary thing. And so before the pandemic, that happened just by going to the place. I did a lot of work with Massachusetts Job with Justice, just going to their office and connecting with their staff, or going to spaces, or the student immigrant movement. But when we're all supposed to be quarantining and we're all separated from each other, then technology becomes needed. We have to connect somehow. And you can't share such information about being undocumented. And even if you could, you don't feel comfortable to do that in a space that can be hacked, that information is accessible to everyone. So you need encrypted. You need something that's protected. And so when I did work with JWJ, though we'd have the conversations without any identifiers in more public spaces, we then moved to platforms that were encrypted, or platforms that wasn't in the US in terms of safety, the government comes looking, to have more intimate conversations. And see, this goes back to just communities having to be scrappy. There is nothing that sort of says, let's involve their voices so we make sure that we create the platform that actually meet those needs, because then we had to use another app to have conversations or talk to people and not share your cell phone numbers, because we didn't want, if the records were asked for, we didn't want, the government to know, like, who to track that person back to their call, and even to question you as the person that's asking for that information. And so it depends on sort of what's needed for the community. I don't know if I answered your question.
Yeah, that's it.
So going back to the question on what do we need to see so that technology can serve the communities that are feeling the most pain, I think that it really is, we have to start by building on what many have said about making sure that you are co-designing, right? Not just who's at the table that someone else said, come here for this one thing and then go home, but to actually co-design, but not stop there, right? It's really important that there is co-implementation, that you are understanding the incredible assets that exist in communities that many would say are like asset deprived, but there are a lot of assets in communities, the scrappy community organizations that are not being funded, right? And so we need to build into any plan, whether it's for technology or anything else, the co-design, funding implementation at the community level, and especially funding and co-designing evaluation, and to be in a mindset, that technology is very good at, which is like we have the beta test, and then we have 2.0, and then we have 2.1, and 2.1.2.3 as you continue to iterate, but based on what the community is telling you, is saying for themselves that they need.
I appreciate that. And in your world, are you seeing any of this, any of that type of formal, engagement with communities?
I'm seeing it in kind of the missions that are being written up, but not in action
Not in
yet.
execution.
And I think it's really important.
What would incentivize that? In your view, and what are ways to move that forward?
That's a great question. I think there's a lot of different potential solutions, but I do think it depends on sort of what application you're thinking. It's hard because it's like sort of sitting in different people's courts. But I think some of it in some spaces will be more regulation to kind of push this forward. Some will be coming from the community and like listening, and hopefully organizations will sort of rethink kind of what their priorities are. But I'm not quite sure. I don't quite know where that incentive pushes, to be honest.
Yeah.
And then you can piggyback it, right? You can have the regulation that requires the community engagement, right? Like, what's a great example of that we know from public health? The community health center. And not to say that they're all perfect, but it's written in the law that they have to have community advisory, things. What are they called? Tables. At community advisory board, thank you, 51%. So there are ways that we can change the landscape of what is required so that these capitalist endeavors can serve the community better.
I think the additional way is, as we had heard earlier, it's about the money and it's about where it goes. So requiring that at their board level, right, at their C-suite level, where those questions are being asked, where the beginnings of that creative voice is happening, that there's representation at the table. And I don't think we should be complacent about that. That there is enough expertise around to be able to make sure that there's adequate representation at the level where the determination is in terms of where that money is channeled. In terms of accountability, I don't know if you can get to that question later.
No, please go.
I think this is where the point I wanted to make earlier was just that 20 years ago when we talked about unequal treatment, and we were so focused on, does it exist, right? And focused on the current healthcare system, the way it exists. dividing and trying to provide a framework around the current healthcare system. And I think we missed an opportunity, which is that we have that opportunity now, is recognizing that healthcare is very dynamic, right? That it's no longer just institution-based within a health system or ambulatory-based within a community clinic, where there have been several efforts around regulations, accountability of the care that's provided, several measures, not enough, but several. But really, the reality is that now people are seeking health care in the Walmarts, right? In Apple now is providing care. It's a different world in terms of where people are seeking health care, and therefore we have to think differently in terms of that level of accountability and those ongoing mechanisms of accountability that we didn't necessarily take into account before.
Yeah, go ahead.
Yeah, if I could add to that, thank you so much. Because what we're seeing right now is that two things. Is one, people are not necessarily looking for a hospital home because they've received their health care. And the unequal treatment at 20, I was just thinking, like, I'm 26, so this 20 years ago is sort of when, just recognizes there's unequal treatment, so that really blows my
I
mind.
think I presented to your first grade class.
So, yeah, that's really, but, so their experiences, they're not necessarily looking for a hospital home. And so they're getting their health care from their churches. They're getting it from their community centers. They're possibly getting it at schools. And in terms of more secondary, like next step specialized, then they're going into the hospitals, things that can't be sort of been treated in either health centers or hospitals. And we even see a shift, not just outside of larger hospitals. In Boston, that's BMC, but also outside of health centers. So when I was growing up, if you're having an issue, you just go to the health center. But if I could bring in my own lived experience here, I've been turned away from health centers multiple times for being uninsured. And so when that fails you, then you go to your church to see the nurses there and get the treatment that you need. And they're doing it because it's an act of them being God-fearing. They're doing it because of their religion and because helping your community and being a part of your community is an integral part of their religion. And then the other thing is that people are looking for an opportunity to decentralize, right? To get healthcare out of these spaces. And so in terms of, I bring it back to the pandemic. I think there's a missed opportunity here during the pandemic. There was community centers, libraries providing wraparound services in addition to vaccinations. And there was this outpouring of unrestricted funds that supported that work. So if I can give an example, there is a function hall where my uncle, he had his wedding reception. I got vaccinated there, but not only that, they were doing food distribution funded by the same money that came from the pandemic. And what happened after shifting away from the pandemic is that so did the funding, and a lot of those wraparound services couldn't be funded anymore. And not only the services themselves, but the staff that was showing up, the people that were showing up to do those things. Then they had to go back to work. And so community-based organizations are coming in right now, and we're working on this together through our community health hub model, is that we're trying to maintain that energy that happened during the pandemic of understanding what draws people to these spaces are the people themselves and their connection to those people. So I'm really excited that we brought up the idea of healthcare happens not just in hospitals, but primary care really happens everywhere in the community. And it gives us an opportunity to reimagine what health is. And I led an activity with a group of youth that asked them, what is personal health, what is community health, and what is prevention? And they mentioned stuff like art and mentors and community centers and not having violence in their communities and having access to they said stuff like clean skin and hygiene. And so it becomes a lot more expansive. And when we expand the thought of healthcare, then we can think about what technologies can be supportive in that space. But if we're still sort of like tunnel visioned into this is what healthcare is, it has to happen in a hospital, there's no way to actually engage that and create infrastructures where we can say, let's take these resources out of centralized, professionalized spaces, out of traditional healthcare spaces, and actually inject them into the community and embed them in an accountable way.
I appreciate it. Yeah.
I think that's one of the things that I absolutely loved about California's efforts, that campaign that happened, I don't know how many years ago, about Health Happens Here, because it was very clear that health, first of all, the health is not just healthcare, that health needs to happen structurally anywhere people are, basically. And so one of the things that we at the partnership are really excited about, and actually it's happening tomorrow, is that we're launching a project funded by the Robert Wood Johnson Foundation that really looks at healthcare as healthcare provider institutions as a sector of how they need to be showing up more to provide whole person health. And in our case, we're applying those principles specifically to maternal health. And really underscoring that healthcare provider institutions are not just, don't only have the role of providing care, but also underscoring that they have a role as employers, and there's a lot they can be doing in terms of how they support the health of their employees and how to have a diverse healthcare workforce that can actually produce equity, which is the whole other thing, that they have really important roles to play as community partners, right? Of not just saying, oh, you know what, community health workers, what a great novel idea, as if it hasn't existed for hundreds of years. Let's hire a few. Like, no, there are plenty of organizations in the communities that you're focused on that have them, pay them, like get into contract with them so that they can do what they need to do in the community. And then finally, they have a huge role to play as advocates, right? Advocate for more than, you have lobbyists, you spend a lot of money, go check how much money the healthcare sector pays in lobbying right now. Use some of that to lobby for the kinds of delivery reforms and payment reforms that will actually produce better outcomes for these communities in technology and beyond. But right now, you can't separate technology from almost anything. So.
Yeah, and technology, I mean, it's such a, to Anna's point, I mean, there's so many different, we've kind of combined a bunch of technologies, from diagnostic to algorithms for decision to user interface for people in the community. There's so many different ones. It seems like there's a couple of common threads. Representation in all of that is important, kind of engaging people around development use, what technology to develop, how it could be used, are all kind of critical success ingredients that you all have called out, right? I mean, I think across those, but yeah.
In many respects, I think about, again, don't want to underestimate the value of just listening to the patient. I had the opportunity to help review maternal mortality cases over a 5-year period 10 years ago, and then we re-reviewed another set of 5 years to see what could have been prevented. What could we have done in the healthcare system that could have altered one patient's care? In many respects, there were complex answers, but the reality is that we have to be careful in relying on our technology and what the technology is telling us and not listen to that patient. And in many respects, I think that was one important cause of some maternal mortality, in that they relied on what the CT scan or ultrasound was telling them, not what the patient in front of them clinically was telling them. Yeah. And so we do have to, like I said, it's a tool, but it's only one tool of the many that need to be used.
I appreciate that. Yeah. So be careful what you ask for. I have 58 questions here. No, I'm just kidding. It's a joke, just a couple. But thank you. Not 58, but we got 6 or 7, so that's good. Okay. That's good. All right. So we're going to go to audience questions here. So anybody take this one. So when we talk about engaging community members and we bring them to the table to guide innovation, what types of guidance are we asking from them? And I imagine it depends on what we bring to them, but are there some general principles on on kind of what we would ask. Yes.
Well, I would start with what I call the vanilla ice principle.
The
Which
wrapper or
is-
the drink? You have to tell
No,
us. Yeah.
the wrapper,
Okay.
which is stop, collaborate, and listen.
Okay, so how many people get that reference? Okay, let's see. All right, good. Okay, so we got about a third. The younger generation, Vanilla Ice. Just Google him. He's had a song, Ice Ice Baby, and Stop, Collaborate, and Listen. But go ahead.
And
please.
I would flip it to like listen and collaborate, right? You need to be able to like the rate of what corporate America tries to do so fast is incompatible mostly with what real engagement requires.
Right.
Right? Because you have to create the table, create it not in your corporate offices, create it out in the community. To do that, you need to create real trust in relationships. And we all saw with COVID what happens when there is no trust in the healthcare system, right? And what solved that? Engaging community organizations, promotoras, community health workers, community health representatives to be part of the solution because they already know, have the trust of the communities that they are in, and what will work and what will not.
Yeah.
So it's really, really important that you are ensuring that you're creating safe spaces where people will feel that they're not just having data extracted from them. And by the way, they're experts in their communities and in their lives. They're not getting paid for that expertise usually, right? And you corporate person or health system person or nonprofit person is getting paid a salary to be in that space. And so making sure that it's not just, here's a table, come to us or forget it. Come to us in the way that we're asking you to, and talk in the language that we're asking you to, and start with the issue that we're asking you to, and actually stop and listen. What matters to you? What problem do you want us to try to solve together?
You want to?
Yeah, I think the issues that we're coming with anything at all. I think if you're already coming with a question or a problem or a solution or a tool, you're already assuming that you know everything, right? And so that's sort of how I approach the work that I do, which is like this weird dichotomy because I'm from the community, I live in the community, I was raised in the community, but then I also get paid to do this work. So it's kind of this 1 foot in, 1 foot out type thing. But I approach all of our work happens cross-sectorally, and we don't have any tangible programming or resource that we're trying to provide. We operate under the assumption that Boston already has everything that it needs, and there's a lot of assets in the community, and community has a solution. So then when I come into these spaces, I'm usually there to listen and to understand, how can I serve as the negotiator? Because when you're in community spaces, you're a collaborator, but once you get into health systems and interfacing with that system, it becomes a negotiation on behalf of the community. And there's a lot of give and take and pushback that happens. And so, yeah, you can't come to the table with having any kind of preconceptions of what you think is going to work, because oftentimes that's not even the case. Even within communities, I'm in the Caribbean community, there's people that are documented, lived here, documented, came here over as citizens, and there are people who lived here undocumented. There's 2 different lived experiences, and what's going to work for one is not going to work for the other. So you can't come to the table with any kind of understanding that you know exactly what's needed.
Yeah, that's powerful to think about. Once you've come to me with something, you didn't engage me in the first place.
I'll
So
give
it's
you
really,
a cautionary tale, which is almost hilarious if it wasn't so sad. I was once asked to engage with a bunch of, let's say, very white oral health advocates about how to engage with the community better about getting water fluoridated. And this was literally just weeks after what happened in Flint blew up. And I was like, do you think they care? Right? They want to first not get poisoned by their water. And what good is fluoridation if they can't drink the water that you're fluoridating?
that's a good point.
And that was very destabilizing for them because they didn't even think to come with not the question of, here's the thing I want you to do, but actually asking, what is it that you need?
Yeah, no, I appreciate that. And I'm going to turn to you. The question here, trust and mistrust really reared its head, especially during the pandemic, and there was a sense that our history of racism, segregation, medical experimentation, and the like, obviously has left many communities mistrustful. And how trust or mistrust translate to the tech space in people's concern for use of their medical data, use of their tracking, for ways in which, number one, they don't have ownership, number two, they don't have knowledge about. So any reflections there on kind of, because this engagement would require trust, and just thinking about that trust piece as it relates to, we're here to help you, and we'd like your information to help you, and how could that information be used?
So I have a friendly amendment to your premise, which is that people talk a lot about the historical experiences and gloss over the contemporary, constant, in some cases daily experiences that people face trying to get health care in this country, right? I will never forget, like, a wonderful event that back when I worked at Families USA that, I'm sorry, I'm blacking out on your name, Professor Williams, talked about the work that the Robert Wood Johnson Foundation did about the extent that people experience discrimination today, or back then, 2018, in trying to getting health care. To the extent that they had data about people who said, you know what, I'm sick, but I'd rather not even try to get health care because I'd rather not be humiliated and treated with discrimination and racism, and I'm just gonna stay home, right? So that's the first thing that I want us all to really internalize. Yeah. That it's not like, when people say, why can't they get over? It's like, get over what? I was just mistreated 2 weeks ago in this doctor's office. Yeah. When my son was born, nobody wanted to listen to me, and I almost died, right? And that's a true story. That's my particular story. Look me up. There's a mini doc on the Washington Post. But that is the first thing, right? The second thing is that, there's some really innovative, interesting models around, again, that's why it's so important to co-create. To make sure that people understand, like when you go into some Native American tribes to do research, they have their own IRB about who owns the data, and it's not the researcher. Right. Right? Yeah. And so there are ways for us to rethink what it means, and whether we're talking about Henrietta Lacks or what's happening, across, in so many different spaces, people need to be able to own their data, and that is completely against the business model of technology today. No, and that's what I was thinking, Anna, for you. In your role, as you think about this trust, the intersection between trust, owning of medical information, artificial intelligence being generated by a lot of information to create decisions. How do these things come together in your view?
Yeah, I think they're being incorporated in the design principles. So instead of things being automatically opt out, they're opt in, and a lot more thought into how to be transparent about what data was this trained on, where is it being used, what is it doing, and so thinking about how to design technology to incorporate those principles is kind of a big focus at this time.
I'd like to not have to I know. When the thing pops up about the new update from my iPhone, I don't have a choice to decline it. I really don't have a choice. If I want my phone to keep working, I got to accept whatever's, in that 30 pages of fine print.
And they call that transparency.
Yeah, exactly. Well, I saw it, but I didn't have a choice. Go ahead.
I like Cynthia sort of statement when we were talking about the planning of this panel, where it's almost like you need that black box warning or the red box warning of any tool that you're utilizing to say, recognize there are limitations to what you're using, and it may not represent, the kind of patients that, that reflect your care. But here's the data.
Or your patient's care.
And so, in many respects, it is about demanding, requiring some caveat or some ability to either opt in or opt out, but some ability to be reminded about the usefulness or lack of usefulness of that one technology or that one assessment.
It's really, thank you for that. And I just want to bring this question forward. I think we have just a couple of minutes. This is complicated, but it's interesting. So, we talk about a lot of these algorithms being built from information. And the question is, what role do you think proprietary algorithms should play when AI has proven to result in disparate levels of care. So the question is, how can due process protections in terms of challenging a denial of services play a role if communities do not have access to their so-called decision-making insights? The big paper that came out a couple years back, that looked at an algorithm that many large health plans are using that would refer people to care management based on how much of the services they used, really had a very large disparity in who got referred for services. Right. So any thoughts or reflections there on that? And that was a big lesson learned, a published paper. But
I think I would then turn to Greg Block and others in the legal field to say, help us, help us think through the kind of terminology that we need in terms of looking at that level of accountability for the usefulness of those technologies, because you're right, it's it's the data coming in and how useful it is with the data coming out. And a lot of times we forget, we're too quick in terms of, we're just too busy to think about how was that data derived. And I think we really need to train our youth to think about it that way. And I think they're actually more savvy about it now than certainly my generation in terms of thinking about what data is being presented to them.
Yeah, there's a question here around how do you broach the digital divide for patients, especially elders living in rural reservation communities, especially when there are cultural barriers? For example, some cultural norms around eye contact being disrespectful in an example, or interpreters not being available for some native languages, or the concept of, the reality of underfunding of the Indian Health Service. How do we bring technology to that environment, particularly when it's already years behind just around some of the basic platforms, information platforms? Easy question in the last minute here for everyone. Yeah. No, and anybody, no. I'm looking at you and you're looking away.
Can I just say something?
Please.
I really want to hear what you want to say, but we have culturally linguistically appropriate standards, right? That were designed at the federal level in terms of what should be required with services that are provided. And this is where we have opportunity to say, look, we don't need to redo that homework. It's a framework, and what should be required at the institution, what should be required within the system, and what should be required with the actual one-on-one care. And utilizing that kind of framework to say that we speak to patients in the language of their choice, and that should be required. That we listen, that we have open-ended questions, so that we're hearing from the patient where they are and what they're trying to tell us. And so, in other words, I think that there are ways that we can require this in terms of that level of accountability for the type of reimbursement that they will receive.
And the last thing that I would say is that assuming there is broadband in the place that you're talking about, and that's a sketchy proposition to start with, I don't want to hear any more excuses about we can't find the right translator. If you are on Zoom, you can open another window and find translators from all over the freaking world to be your translator.
The patient will tell you that.
Right, that's not a thing anymore. And anybody who tells you that is just trying to pull wool over your eyes. My son was in the ER a while back with some mental health issues, and I could not believe there were just not enough to go around services. They found a psychologist from Puerto Rico to talk to us in Fairfax, Virginia, which he loved, right? Because it was cultural competence rather than some random white guy trying to talk to him about, his thoughts and feelings and concerns. So that solution, again, if we have broadband, that is an easy one. That is an absolutely easy one.
Yeah, and I think, thinking about this particularly, just raising again this point of Indian Health Services, really thinking about areas that are rural, underfunded, how those issues are cross-cutting, really, really important. So I think we're just at about time. Please join me in thanking this great panel. Appreciate you all. And thank you for the questions, by the way, and I think we got a lot of great information. I'll turn it back over to Brian.
Thank you so much. Again, let's thank this wonderful panel. Really outstanding. Thank you so much. So we will now take a 15-minute break. We'll convene back at 2:30 on the dot because we got another exciting panel on political and legal determinants. So please come back at 2:30 on the dot, and we have some more exciting conversation for you. Thank you. We'll see you back in 15.